Our next speaker is going to talk about the experience in Scotland with utilisation, and that's Giles Roditi.
Good morning. Kind of similar. Let's get going. Interspersed with a few more images maybe. So I've looked at non-invasive angiography trends in MRI and CT share over the last decade, prior to the pandemic and then the pandemic, looking in Scotland. The motivations are, well, we know that it's transformed how we deal with patients, our use of non-invasive imaging. I, when I started as a consultant, had a regular invasive angiography list where I stuck needles into patients' arteries day in, day out, but we don't do that anymore for diagnostic purposes. And really we wanted to see what's been happening in the decade running up to the pandemic and thereafter so that we could inform not only research but also planning for the head in Scotland, you know, what kind of scanners we're going to need and what kind of personnel we're going to need to interpret the examinations. The National Health Service in the UK, we have an unofficial motto, and it's "We are where we are." But it's often useful to know actually how we got to where we are. This is how we started in Scotland. This is John McIntyre, who was an ENT surgeon who set up the first hospital X-ray department in the world in the Glasgow Royal Infirmary where I work. It wasn't known as an X-ray department, it was called the Electrical Pavilion. And this is a picture of it here. And John McIntyre actually invented the chest X-ray. This is the first clinical chest X-ray ever performed in the world. It's a child who'd swallowed a penny that got stuck in its throat, and he wanted to know whether he could get it out or not. This exposure took about 20 minutes. The mother holding the child, and we don't know what the radiation dose was. And the letter there is from Lord Lister inquiring about what had happened to the child. I trained in Aberdeen, which maybe some of you might know is a centre of maybe the world's first body MRI scanner, the Mark I. This is Tom Redpath and Frank Smith, who mentored me in MRI, and this is Bill Edelstein with the Mark I. And this is the first MRI of the heart, which is unpublished, and Frank tells me that this actually predates Damadian's picture of the heart in 1977, but maybe only by a few weeks. I started doing contrast-enhanced MRA when I moved to Glasgow in 1998, and this was revolutionary at that time. Because until that point, if we wanted to get images in a patient who had a Leriche syndrome with an aortic occlusion, we had to stick a great big needle into the aorta itself through the back and inject contrast, and we didn't get a 3D image. And at this time, we didn't have CT. CT angiography did not exist, so this was mind-blowing stuff, and it really changed what we did. I went for my first MR Angio Club in 2000 in Lyon, which was organised by Philippe Duec, who's a very clever Frenchman who's not going to be with us for this meeting, unfortunately. I didn't know it at the time when I went to that meeting, but he'd actually organised a second meeting at the same time, which was the first international workshop on coronary angiography using MR and CT angio. So he was riding two horses. And Philippe remains at the forefront of CTA. In fact, he's doing a lot of work with photon counting CT. And that's something I want to touch on is evolution, because CT has evolved dramatically since the early days of MRA, since this society was set up. CT has come on in leaps and bounds. As I say, in 1998, CT angiography didn't exist. I didn't do CT angiography until about 2004, when I got a 4-slice CT scanner. I now have several 320 detector OCT scanners, and we're now moving into photon counting era. So CT has really evolved. And so the humble chest X-ray has evolved additionally. This is a young woman with unexplained breathlessness and a clear chest X-ray and elevated D dimers. So we do a contrast-enhanced chest X-ray. That's what we do about a dozen of these a day in Glasgow Royal Infirmary, I think. Well, it's not a contrast-enhanced chest X-ray, it's X-rays of the chest while we're infusing contrast, but it is just what we call a CT pulmonary angiography, okay, a CTPA. And CTPA, this is a radiation dose. This one diagnosed quite massive pulmonary embolism in this 22-year-old lady. It's 5 millisieverts, but that's 5 millisieverts that's well justified in a patient with a life-threatening condition. And radiation dose has come way, way down. You may not be aware of this in the MR community, but for instance, this is a colleague of mine. He replaced his CT scanner and he happened to scan exactly the same patient 8 years later and found there was a 38-fold dose reduction. That was between 2006 and 2015, and that's only advanced. Okay, we now have scanners that can do a CT plain and post-contrast CT pulmonary angiogram and subtract them and get an iodine map, all for about 1.5 millisieverts. So that's two CT scans of the chest, including a contrast-enhanced one, for really a very low radiation dose. And we can get CT coronary angiography in a single heartbeat with a 320 detector row scanner for extremely low radiation doses. So radiation is not the big bugbear that we used to have in the early days. And CT, we could not possibly image this kind of patient with multiple coronary stents. With MR, there's no way we can image this kind of thing. We can see inside these stents now with advanced CT systems. So what about Scotland? We've got 5.5 million patients in Scotland, nowhere near as many as Medicare. We have 11 terrestrial health boards, which are mapped out here. But the one unifying thing is we have one PACS to rule them all. Okay, we only have one PACS system for the whole of the NHS in Scotland. All 5.5 million patients have their imaging on one PACS archive, and it's the same vendor since it went in 2007. We have a Carestream PACS. And we have a lot of atherosclerosis in Scotland. This is a cross-section of the average Glaswegian's carotid artery. Or something like that anyway. Scotland's a beautiful country, as you know if you came to Glasgow's SMRA a couple of years ago. This is our methods for the long-term data. We got governance permission from the powers that be in Scotland to actually look at all the data going back to 2009 to 2019. So that's 11 years in total for that decade. And we could query Carestream. If you've got version 12 of Carestream, there's a hidden field which you can put in a code and you can actually extract all the data of the number of exams, etc., that were done over the whatever period you want. We also looked at more detailed data from our radiology information systems in 2 health boards. My own health board, Greater Glasgow and Clyde, which is 1.2 million people. This gives us richer data in terms of the time of performance, the nature of the patient, what kind of patient, they're an ED patient, an outpatient, all this kind of thing, how long they've waited. And also a more rural one, which is Forth Valley, 300,000 population. And we did exactly the same thing for the COVID pandemic period. So these are our results. There's been a 45% increase in all non-invasive angiography over the period in a district general-based hospital. There's several district general hospitals in Forth Valley. And in a teaching in urban environment, Glasgow, we've got a 72% increase. And CT pulmonary angiography accounts for 48% of all those studies, with an increase of 55% over those 10 years. So just before the pandemic, we were doing 644 CT pulmonary angiograms per 100,000 population. Coronary studies have also increased 3-fold. Yet the share of total studies performed with MRA has fallen from 40% in 2009. We were doing 40% of our non-invasive angiography with MRA back then, now to 33% in Glasgow. And Glasgow is where we do a lot because of what, because of who I am and how I've pushed it. We do a lot more than other health boards. And in a district general environment, only 25% of non-invasive angiography is done with MR. Here's some more specific results. This is lower limb angiographic studies. This is Glasgow data. As you can see, there's an inexorable rise in CT angiography from about 20% when we started back in 2009 to it's now overtaken MRA, which is falling off a bit. MRA peaked around 2016. In Forth Valley, the y-axis here has been exaggerated a bit. They don't do anywhere near as many as we do in Greater Glasgow and Clyde. It seems very variable over that period, but because we know what's going on in these areas, we can actually point to things such as, for example, this orange arrow, this first fall in MR angio use. The 2 vascular surgeons in Forth Valley both retired. The service collapsed and Glasgow had to take it over, basically. So there was a huge drop there. It then gradually increased again. And then there's another drop at that point. At that point, why is that drop? Well, I can go in and I can tell you why that is. That's because the MRI machine, was changed. They changed vendor to a different vendor and a different type of system. And basically, they can't get decent lower limb MRA anymore. They've had the application specialist in 3 times, and they cannot get decent lower limb MRA. I mean, I wouldn't use it for lower limb MRA. The images are just awful. And that's one of the reasons that CT angiography has taken over for lower limb investigation in Forth Valley. In terms of carotid studies, there's an inexorable rise in CT angiography. It's increased, 6-fold over the period. Now outnumbers MR angiography a factor of 10 to 1. And in Scotland, we don't do any MRA for ED patients. All our ED patients will be imaged with CT. We cannot get MRI out of hours between the hours of 5 p.m. and 9 a.m. or at weekends. And now CTA. CTA used to be a small part of the workload of the ED departments, but it's now about 15% of our total CTA workload in Scotland. In terms of the COVID-19 pandemic, pulmonary angiography has had a 100% increase in the 3 years of the COVID pandemic. We're now doing in Glasgow over 1,000 scans per 100,000 population. That's 1% of the population are getting CT pulmonary angiography per year, mainly through concerns about the pulmonary vascular thrombosis associated with COVID. And interestingly, although most of our coronary work is on outpatients, there's been an uplift in coronary CTA studies over this period as well, despite the pandemic. Lower limb angiography, MRA, has reduced. We still, in Glasgow, are not operating or intervening on patients with claudication. We will only intervene on patients whose feet are about to fall off, critical lower limb ischemia. And so there was no point in imaging patients who are just simply claudicant, because we're not going to do anything with them. Carotids, again, continue to increase in CTA. Scotland is way behind the rest of the Western world in implementing mechanical thrombectomy, but we are starting to do mechanical thrombectomy. And in the prelude to that, we've had an AI system put onto PACS to analyse CT angiography, and many more patients coming in with stroke are getting a stat carotid CTA at the time of that they arrive, along with a CT brain perfusion. And of course, once you've had your carotid CTA, you don't need your carotid MRA. Venous imaging has increased across the period as well, mainly driven by an increase in cerebral venographic studies related to concerns about vaccine-associated thrombosis and thrombocytopenia. Luckily, we haven't seen very many patients with that, but it has resulted in an increase in imaging. But the share from MRV has fallen down to 40%. And as I say, ED vascular imaging is now exclusively done by CT. So, despite the overall growth in non-invasive angiography over the last decade across Scotland, MRA has shown a reduced relative share compared to CT. The COVID-19 pandemic didn't reduce our non-invasive angiographic imaging in Scotland. Indeed, the volume increased over the pandemic period, particularly from the CTPA, and especially by use in the ED. And I think that use of something like CT angiography in the ED ingrains the belief in junior medical staff who all go through, in their training, they all go through ED, that CT is the way we image blood vessels, and it becomes it's the preferred choice for imaging blood vessels, and even among junior radiology trainees. And looking at all this data, it's quite interesting. It's like watching something in evolution. This is Charles Darwin, and he said it's not the strongest of the species that survives, nor the most intelligent, but the one that's most responsive to change. And maybe as a group, MRA, we need to become the ones that are responsive to change and find the niches that we can fill with MRA that do things that CT doesn't do. But that's my thoughts. Thank you very much for your attention.